Thanks for joining us again. This segment, we met Dr. Oscar Corridor on the last one. He's going to join us again with this one. And Teresa had to step away, so it's just going to be kind of the two of us talking about this, which is going to be good. Kind of going through the topic of the day is Hispanic and Latino eye health. Certainly, we see a lot of Hispanics, and we're lucky enough to have Dr. Corridor, who actually speaks Spanish and English, and certainly can communicate and say things that I sometimes don't know what he's saying, but he certainly can talk to him and explain everything. Yeah.
Probably a good thing. Huh? Well, it's good to be back in the company of the great and Dr. Bell from Teresa Optical. So like Troy said, we're going to be talking about some Hispanic things, and also about uveitis and some inflammation in the eye and other topics.
Yep. So certainly any questions, y'all keep sending those in, keep liking, keep commenting. Certainly the more feedback we get, the better. We want this to kind of be interactive. And certainly we want to cover topics in the future that are interested, that you guys are interested in, or if you have questions on. So keep certainly interacting with us as we go along. But we kind of started this. There are certainly conditions, even in school, we go back to optometry school, we learn certain conditions, and we learn who is more likely to have that condition. Sometimes it's males, sometimes it's females, sometimes it's African Americans, sometimes it's Hispanics. So just in general, I guess are you outdoors a lot, or are you indoors? There's a lot of things that factor in to what some of these conditions are.
Yeah, so just going down the list, unfortunately for most Hispanics in Central America and Latin America, we are right in the equator, so that exposes us to more sunlight. There's winds and there's other elements that affect the health of the eyes. So that, things like pingueculas and pterygiums and dryness and cataract formation, because we're just more exposed to that type of environment.
No, those are all good points. So the things that Dr. Cordo was talking about as far as cataracts, and we've talked a little bit about that in some of our past segments, a clouding of the lens, which eventually could get to the point where it makes your vision blurry, or it makes glare really bad. And a pterygium, pingueculas or pterygiums are kind of the same thing, just depending on the extent of how it's growing over the cornea. But basically, sometimes when you look on the white part of the eye, you can see a brown area, maybe vascular growing. It's kind of growing over the cornea, and that usually happens in patients, and to your point here, that spend a little bit more time outside in the sunlight. Yeah. And certainly, if you're close to the equator, those things.
It's just more exposure. You're more exposed.
So, what would be suggestions, I guess, or things to maybe talk to these patients about as far as maybe preventative measures or things they could do to help maybe avoid some of these things?
Yeah. Well, the main thing is protection of the eye. Either cut the amount of light that is getting into the eye with either a hat or a wide brim hat, and of course sunglasses. I myself, I can't go outside without a good pair of sunglasses, polarized preferably for me, but with a good UV protection to minimize the exposure. There are certain things that we can protect against the wind and the environment, because being in a dusty environment, you might want to have something a little bit more wraparound, or goggles that actually cut down the amount of contaminants or wind and dust that gets into the eye.
Right. No, those are all good things. I know for me, I've gotten to the point, and actually most of my life, where I've kind of worn, like you have, polarized sunglasses, and even on overcast days for me, I'm just so used to having that protection that
absolutely,
it's hard to go outside without it in the sun. And it's just kind of, I think sometimes it's just getting in a habit. I think and I have friends and victims of this, when they go out and do yard work, they just go out there, where if they'd had the sunglasses laid out, or maybe the hat laid out ahead of time, or maybe planned it, a little bit in advance, versus just getting out there working, getting sweaty, and then forgetting about it, or saying, hey, I don't need it at this point. So those are all good suggestions of things to help, because, one day out in the sun, probably not a big deal, but weeks and months and years.
And it's the years of exposure. And another thing that affects Hispanics, especially here in the United States, since we're celebrating Hispanic Month, it's a lot of them spend time outdoors doing migrant work. So they're really exposed to chemicals from plants, picking up fruit and all that stuff. When I lived in California, you're driving around, and that's primarily what you see is a lot of Hispanics work in the fields. So again, exposure, but you do see them, with brims and sunglasses. So at least some of them are aware that they need to be protecting their eyes.
Well, I have certainly seen a few over my years that did have, whatever it was, a chemical or some exposure, something got in the eye, they were working on this or that. So, for us, we're booked out with full exams, but we're always available to take an emergency office visit. Certainly, we've got 5 locations. You can go to TeresaOptical.com, give us a call. If you had that injury, you had something that got in the eye, it's red, it's hurting, come in. We want to help you before it gets really bad, because some of those things can turn nasty, especially if it is chemical exposure.
Yeah, absolutely. And even just something as simple as a pinguecula, it can just get inflamed and irritated, and the next thing you know, the eye is hurting and it's red and it just looks bad, and we can take those patients like that in between, we accommodate them, obviously, at all of our offices.
Yep. And we take pretty much most, I'd say 98, 99% of both medical insurances and vision insurances that are offered. But even if you don't have any of that, we certainly offer self-pay office visits that start at $50 and can go up a little bit from there. But, certainly you don't have to have insurance to come in to see us. Even if it's an emergency office visit, you don't have to have medical insurance. And I think a lot of people are scared not to come in because of that reason. I don't have insurance. And then a lot of the medications we prescribe, there's possibly a generic
generics.
version.
We go generics.
With good RX that may not run you, but $3, $5, $20. So, it's not going to be hundreds and hundreds of dollars.
Absolutely.
A lot of people would think.
Yeah. No, I never prescribe anything that is brand name or is going to cost the patient an arm and a leg, to go get it filled. That's not the point. The point is to get the patient treated and make them feel good, get their eye to feel comfortable, and obviously to heal up, and so they can go about their business.
And we do our best to let every patient know prior to the visit, or at least once they check in, what's the cost going to be. We don't want to do everything on the back end and say, hey, this is what you owe us. We're not trying to do that. So we try to get everybody prepped as far as, hey, this is what to expect today. And I'm along with you. We certainly want to try to get the best drop for that patient, but we also want to try to get the most economical, most financially, best available. So we search, whether it be phones, we'll call pharmacies, we'll figure out where that patient can get the best deal on the medication that they need to get.
Absolutely.
So we talked a little bit, you mentioned, we both mentioned cataracts, pingueculas. Let's talk a little bit about diabetic retinopathy for a second.
So unfortunately, as Latinos, Hispanics, we tend to have more genes prone to diabetes and glaucoma. Why, I have no idea. I don't remember. It's probably something they taught me in school, and I don't remember the reason, but I just know that we're more prone. Yeah. So that's some of the things that we look into our patients, especially when they come with diabetes, cataracts, glaucoma, or any other condition, high blood pressure, because unfortunately diabetes and high blood pressure kind of tend to go hand in hand. And those are the things that we're going beyond just getting the patient to see well or see it 20/20. We go beyond glasses to let's look and see what's going on with the health of the eyes. And for us Hispanics, and everybody that comes to our office, those are our priorities, is to make sure that the eyes are healthy, and if they have a medical condition that we treat it properly, or that we refer to the next level of care if we need to.
Well, diabetes in general, let's just say, certainly for the patients who have big fluctuations in blood sugar. Let's say those patients that are uncontrolled, or maybe they're working with their primary care physician to get the blood sugar under control. If you have those big fluctuations, usually as the blood sugar increases, it can make the prescription of what you see different too. So patients will say, hey, I saw clear a week or a month ago, but now it's blurry. And a lot of that could be to the blood sugar going high or going low. And so, certainly we want to take that into account, but also the more fluctuations you have, especially long term, probably the more likely you are to have issues or problems or bleeding in the back of the eye. And those patients, certainly if you're diabetic, even if you're borderline diabetic, we want to see at least once a year to kind of look in the back of the eyes, to dilate you, to check the health of the back of the eyes. And if there is mild or moderate or severe changes going on, we're going to see those patients maybe every 3, 4, 6 months, depending on how the severity is. So the main thing with that is, come in for an eye exam. Certainly it's one thing to check your vision, but also we want to check the health of the eye, because most diabetic patients that I see, if we catch it early, we can help you. It's the ones that come in 5 years or 10 years later when they have this bleeding or they've already lost vision in one eye.
Yeah, it's too late.
At that point, it's sometimes too late.
Yeah, it's too late. And we in our offices, we always look at the newest and greatest technologies that will help us predict or at least catch things at an earlier stage, so that we need to, so we communicate with the primary care provider so that they can kind of control, okay, we need to get your sugars at this level because the eye doctor is saying, hey, you got a higher risk for developing, loss of vision or diabetic retinopathy within the next 12 and 13 months. I know we've both been using one of our new pieces of equipment. It's like crazy because even today I had a patient that, we looked at the eye, very mild non-proliferative diabetic retinopathy, and of course we did the testing, and this thing is telling me that this patient is going to have an incredibly high chance of developing diabetic retinopathy within the next 12 months.
Right.
And I'm looking at this patient going, whoa, we need to act now. I didn't scare the patient, but I told him, we need to do something. We're gonna talk to your primary care provider. We're gonna get all this stuff, under good control, and we'll go from there.
We're lucky enough to work in a profession where we're getting new instruments that developed all the time. I mean, it's almost getting to the point where our diagnostic equipment is better than some of the treatment options that are out there.
Absolutely.
Like we're able to pick up stuff so early, but treatment, the treatment on the flip side has to catch up to that. But it is nice to have something where we can say, hey, Miss Jones, we're seeing this, you're going this direction, or this doesn't look good, and to catch it before it actually becomes bad. I mean, I think that's the goal, and that we hear that all the time in the news. Preventative care is the goal. And if we can prevent something from happening and occurring, it's better for the patient, it's better for the outcome, it's better for everybody.
Absolutely, yeah. I mean, preventive care is always going to be cheaper than reactive care. Once there's a problem with the eye or the condition, then we're talking a lot of money on treatment and extended treatment, versus if we can keep it from getting to that point, it's going to be a lot cheaper for the medical system.
Well, one of the stats I've got written right here is the National Eye Institute reports that 50% of Americans with diabetes may face diabetic retinopathy in their lifetimes. So if you say, hey, it's not me, or everything's good, just remember that
there's
stat,
a good
50% chance. And the longer you're diabetic for, the longer you've been diagnosed or the longer you've had it, the greater the risk goes up. So make sure you're coming in for at least that annual eye exam, and then based on the findings, it may be more frequently than that.
So another little fact to go with that is Hispanics, we make, Hispanic and Latin Americans, we make about almost 20%, not quite 20% of the population. So what you're telling me is that 10% of the population potentially has some problems with diabetes, because like I said, unfortunately it does run at a higher rate on us Hispanics than the rest of the population. So wow.
Well, and we fronted this by saying, hey, the patients already know they're diabetic, but I know you have and I have too. We've been doing this for a while. There are plenty of patients who came in for an eye exam that hadn't seen a primary care physician. They didn't know they were diabetic. By looking in the back of the eyes, we were able to say, hey, have you had your blood sugar checked? Maybe you should go into your primary care. So that is a way we can tell a lot by looking in the back of the eyes.
Absolutely.
We talk about major things that can happen to the eye, but even blood sugar, blood pressure, cholesterol, we can tell a lot by looking in the back.
Yeah, absolutely. I had a patient a couple of last week, I think it was either Thursday or Friday, that had a little bit of suspicious bleeding inside the eye that turns out to be carotid stenosis. So blockage of the arteries that go from the heart to the brain, and if those get blocked, and you throw a clot, then you got a major problem either in the eye or in the brain. So that could be absolutely devastating. Yeah, it could be death. Yeah.
So we talked a little bit about diabetic retinopathy. Let's talk a little bit about glaucoma. I know we've talked about glaucoma in some of our past podcasts, and we've gone into a little bit more depth, but just kind of brushing the surface here. Certainly Hispanics are at a higher risk. There's other that fall in that category as well. Asian, Hispanics,
African Americans,
over 60. Sometimes high blood pressure. Sometimes diabetics have a higher risk of having glaucoma. So that's another reason to come in and get that annual eye exam, is so we can check the pressures, because the one thing about glaucoma, and I know Teresa said this a lot, it's the one thing you don't know you have until late stage. You will not know, because you can't tell until you've lost all your vision, and that's usually late stage that you even have glaucoma.
Oh, absolutely. Personally, glaucoma touched my family. My grandma went blind from glaucoma. I don't know if it was, dynamics back in the 50s and 60s were totally different than what they are today, and either she just didn't have the money to get care, or she just didn't want to get the care, and eventually she went blind from glaucoma. So I get my exams at our office with one of our doctors once a year, because it runs in the family, and I'm Hispanic, so
Well, I think some people are cautious because of treatment, like certain conditions, like, oh, I hope he doesn't diagnose me with this, because the treatment for glaucoma is really nothing to lose sleep over. Most patients who have glaucoma, we're going to start them maybe on an eye drop to use at bedtime. That's probably a first line, maybe a second drop. There's some surgery options available. So, using one drop in the evening to lower your eye pressure is certainly far easier and better than letting it go and then losing your vision permanently where you don't get it back.
Yeah.
So the treatment is really nothing to worry about. We just want to figure out if you have it or not and what we need to do.
And then we need to treat it, and technology is getting better. We don't have access to the newer lasers that here in Florida, at least, we don't have access to the lasers. But the younger the patient, I tend to be more, let's do a treatment with a laser that is going to buy us maybe 5 or 10 years that we don't have to use drops. Because once we start drops on a patient, they're probably going to be on a drop for the rest of their life unless they have surgery. And by the time we get to surgery, that means the case is getting complicated.
And so most patients that we certainly have glaucoma, we start them on drops, let's say, that we follow those patients typically every 4 to 6 months, I guess, sometimes based on the severity, because we want the drops to make sure they're working, but we don't know that unless we check it. So we're checking for any progression, we're checking to make sure, because once you lose that side vision with glaucoma, you don't get it back.
No, it's
done.
So
we want to do all we can in our power to hopefully help you on the front end before it ever gets to that point, because once it's gone, it's gone.
It's absolutely gone.
We talked a little bit at the beginning. We kind of covered cataracts and pterygiums,
being
in the sunlight and close to the equator. Let me go to questions. I've got one question from a patient that sent it in. Do you have any bilingual staff at all of your locations to assist with making appointments and conducting exams?
Well, that staff would probably be me. I do sometimes get called in to the front to answer the phone or talk to a patient that, of course now we got technology in our cell phones with, translate or apps that translate, but we are a little limited on the folks that speak Spanish. Some of our doctors are learning how to speak Spanish. I know the office in Milton, I think I'm the only one that speaks fluent Spanish, and Palo Fox, I think I'm the only one also that speaks fluent Spanish, but we do have some help, and I think you have
at Fairfield, where I work predominantly, we're lucky enough to have actually
two. So that helps immensely.
That both speak very, very good, so they're able to assist and help with that. So I would say, out of the 5 locations, we
cover 3.
That's one thing. When you call up, go to the website. If you only speak Spanish, let us know that. We'll certainly get you in a location where maybe Dr. Corridor's working that day, or we have other staff members that can assist to help, to translate, figure out what your problems are, and to talk about the treatment, plan options. So I know that's much easier. It's hard to speak with someone.
It's a language barrier. Is kind of easy to overcome. Obviously, if I'm in the office or if you got your text with you.
So we want to work with you. So certainly give us a call.
Absolutely.
And we'll figure out. We want to thank you guys certainly for doing this podcast. Thank you, Dr. Cornwell, for joining us.
Thanks for inviting me. Appreciate the offer.
Like us, YouTube. We're on some of the channels. Certainly, send any questions, any comments. We appreciate it. And until next time, thank you guys. Thank you.
We'll see you.